Welcome back, everybody, to the Wellness at the Speed of Light podcast. I'm honored and privileged today to be with actually one of my partners, a world-famous neurosurgeon, and I don't say that lightly. Dr. Eric Nussbaum is joining us today. We're going to talk about a ton of things, but before that, I'd like to do my best to give him a proper introduction. And so his resume is really too long. We could be here all day just talking about all the things that he's done, but he's got 125 papers in peer-reviewed publications. He's got 100 presentations that he's done and 75 poster presentations, both nationally and internationally. He went to Johns Hopkins for undergraduate and then off to the University of Maryland for medical school. Following that, he went to the illustrious University of Minnesota and then off to the University of Western Ontario, which I'm going to ask you about later. He's the author of the Video Atlas of Intracranial Neurosurgery, which is, I believe, translated in 17 languages. No one hold my feet to the fire on that. I really tried to do a deep dive. It's hard. It's in so many languages. Here is an example of one of the copies of his book. In Chinese. Here's another book, Cerebral Revascularization, Microsurgical and Endovascular Techniques, among other things that he has written. We're really excited to have him here today. We're going to talk about a range of topics from neurosurgery to his interest in concussion, post-traumatic stress disorder, depression, anxiety, and other things. And I'm really proud to have someone here who is not only a famous neurosurgeon, but also has gotten into the wellness space, which I've gone down that rabbit hole now for the last couple of years. And when we started talking about it, I was really shocked because I didn't know that about you. It's not something that's kind of readily out there, you know, and available for people to learn about. So I think people are going to learn a lot about kind of your thinking in some of these other, you know, spaces. And so should be really, really interesting talk. So on that note, what I would start with is you're a neurosurgeon. Your specialty is vascular and base of skull. How did this all happen?
Well, I really wanted to be a neurosurgeon for as long as I could remember. My uncle was a neurosurgeon, and he was really an inspiration to me. The opportunity to help people in general, and thinking about medicine as just the most noble profession has always been a part of my thinking. Within neurosurgery, when I was training, for sure, vascular and to a lesser degree, skull-based neurosurgery, they were really the ultimate frontier. It was the most challenging surgery, and it just captivated my attention. Many of my mentors, some of the people who really, really influenced me, this was their interest, and I think that had a profound effect. And it's just been wonderful to be to be able to help people with really, really complicated problems.
I don't want to put you on the spot, but would there be one person that you would consider your biggest mentor or your biggest hero on the journey to becoming a vascular neurosurgeon or skull base or a doctor for that matter?
Sure. I mean, I already mentioned my uncle, obviously. That's more personal.
Right.
But, Dr. Drake, Charles Drake, who was the chair in London, Ontario, at the University of Western Ontario, who I was privileged enough to spend some time with. He's really the father of modern brain aneurysm surgery. Just an unbelievably wonderful person, the most down-to-earth person you could ever meet. Incredibly encouraging. And at the same time, that's juxtaposed on a figure who did things that nobody had ever done, unbelievably courageous in the operating room, and just the most wonderful person in the world. So you put those together, and I think I just took so much away from him after my experience there.
That's wonderful. What would you say, and again, hard to choose, because of the intricacies of what you do, and I'm sure you've seen thousands of complex cases. And by the way, I'd just like to let the audience know that you've done 2,000 aneurysm surgeries and you've done 1,000+ base of skull surgeries, in addition to something called a brain bypass surgery, which is uber complex. In your years of practice, is there a patient that maybe is your most memorable patients, or one of your most memorable patients, or in your top 5, something that we can share with the audience to kind of get a sense of how dire a situation can be, and potentially how your specialty can get people out of that situation?
Yeah, I mean, it would be fun. We could sit here and do a whole day about some of the great and amazing cases that I've been privileged really to be a part of. One that comes to mind is a young man who was out hunting with his family, and he was actually shot in the eye. And what was really interesting about this case is, if you think about it, right behind the eye is the carotid artery. The carotid artery is bringing blood supply from the heart up through the neck to reach the brain. And in this case, the bullet, or the BB, the pellet, actually went through the eye socket, punctured the carotid artery. And believe it or not, this is kind of a 1 in a million type of situation. It actually traveled inside the carotid artery up to its main branch, the middle cerebral artery, going to the brain, and lodged there, blocking blood supply to the brain. So the child essentially presented with stroke symptoms in the middle of the night. He was flown down from the Dakotas. And first we had to figure out what was going on. It wasn't that obvious what was happening. And we ended up, because the interventional neuroradiologists that I work with couldn't go up and pull the bullet out. Sometimes they can actually pull it out, like they could pull a clot out or something like that. They couldn't get it out. And so we ended up doing an emergency brain bypass surgery, which you had mentioned, where we actually bring new blood supply up to that part of the brain. And people always ask, did you take it out? Did you take the bullet out? And the answer is no. So you have blood flow coming up to reach the point where the bullet is, and then you have new blood flow through the channel that we created. Child did spectacularly well. Essentially, it's fully normal, and all of his symptoms reversed. And so that was an amazing case.
There's nothing more rewarding than, when patients tell a physician, you saved my life. I wouldn't even be on this earth if it wasn't for you. So how do you feel like, when you hear those things?
Mostly humbled. I think you're in the right place at the right time. In some ways, I like it better when the patients don't necessarily even realize how dire the situation was. I mean, they're appreciative to be in good shape, but sometimes, you walk out of the room and think, they don't understand how close it was for them. And that's probably a good thing in some ways. But yeah, mostly appreciative and humbled. And I agree with you. That's what recharges you and keeps you going, to come back and do it again.
Oh, absolutely. Because that just shot in the arm that you get from something like that keep you going for years. Thanks for sharing, that with us. We're going to kind of shift a little bit and talk about some of the more, holistic kind of things that you're doing to try to make a difference on fronts that are peripherally related to neurosurgery, but not necessarily what a typical neurosurgeon is diving into and is spending his time on. Before we get to that, though, I'm going to ask you the question that I'm going to ask most of the people when they sit in the hot seat here. Have you experienced sort of kind of what I've experienced, and that is a frustration with seeing how overall we're managing kind of preventative care and looking at patients, and then some of these diseases that do develop? Are you frustrated as I am in the fact that we focus so much on medication management and surgeries and other things? Obviously, without some of the medications that we give people and surgeries, patients they're not gonna live. However, outside of that, for some of these more chronic things, are you frustrated in how we're approaching things?
Yeah, I mean, absolutely. I think that the system is broken. One thing that you alluded to that I think is really interesting is both deal with really complicated medical issues, which we treat typically with surgery.
Right.
And we rely heavily on technology, rapidly evolving technology. And I think it's something that probably we both find very interesting, watching that. At the same time, I think it's interesting that we're we've come to a similar place. And I suspect, and you can correct me if I'm wrong, that part of that is because I can do a surgery, I can repair someone's brain aneurysm, I can take out their skull-based tumor, their meningioma, or their acoustic neuroma. And at the end of it, the great part about it is, they're cured. Oftentimes they're fixed. They can go on and live their life. You can do a big spine surgery and you've corrected a problem. But then what I noticed more and more was patients coming back to me and saying, well, thank you, but I don't feel great. I don't have the energy that
Bingo.
Or I don't have the focus, or I still have headaches. They came in, their aneurysm was diagnosed because they were having headaches or because they were feeling mentally not as sharp as they used to. Can fix that. And yet they still have the original problem. And so for a while, it's like, well, that's it. That's what I have to offer you. But then it started to occur to me that there's got to be something more. There's got to be something that we're missing or something that we can do to help these people more than that, so that we're not just treating an X-ray. We're not just treating, a tumor. Important, don't get me wrong. I'm not minimizing the importance of what we do with surgery, but are we taking care of the patient? Are we really making them better, getting them to be the best place where they can? And I think the answer with traditional modern medicine is most of the time not.
That really is a great answer. But in all seriousness, like, I've been really, really blessed to have built a very large practice, and it's been great. I've seen thousands of patients, and unfortunately, what has really bothered me, really from day one, but I didn't do anything about it because I was too busy becoming a busy, orthopedic spine surgeon and worrying about sick patient after sick patient after sick patient, medication list after medication list. And you nailed it with that, what you said. I don't feel good. And I know that when we first had this discussion many, many months ago, just randomly at a company event, I was like, I wanted to give you a hug because you're just talking about all these things. And I'm like, wow, this is the guy that, I need to be, talking to, because just kind of similar minded. And I found that a lot of physicians now are reaching out to me directly. I just had an endocrinologist reach out to me last night, say, love all the things you're doing. How can we partner? He's big into weight loss, wants to get involved in this movement or whatever, whatever we're trying to do here. On that note, let's go into the concussion problem. I'm an orthopedic surgeon, so my kind of expertise at concussion was only the reading I've done, things I've done in medical school, and then the fact that as orthopedic surgeons, many times we're asked to cover sidelines. And so we need to know enough about concussion to evaluate it, to send them to the right people. But my first question is, what's your sense of how big the concussion problem is? Let's just say in our country. Obviously, it's a worldwide problem, but how big is the problem numbers wise? Is there something like official out there, or are we just guesstimating?
I think we're guessing at this point. I think the problem's a lot bigger than what we realize, especially as youth sports, teenage sports has become more popular and also more aggressive. I think at the same time that we're realizing some of the long-term consequences of head injury and concussion, and those have become more popular, especially through professional athletes, through football players, boxers, that type of thing. We're also at the same time recognizing that there are consequences to even minor closed head injury, a minor concussion, repeated concussion. These types of problems are way underestimated. And you know why? Again, it gets back to the fact that we don't look at it. Modern medicine doesn't look at it, doesn't address it, doesn't have easy and obvious answers for it. And so it goes by the wayside.
I read a study, really interesting study. And so if you ask coaches, athletic trainers, that kind of thing, how many of your players have had a concussion? In one study, it's about 5%. Then you ask the players, have you had a concussion? And you use the term concussion. It went up by like 3 to 12, 15%, something like that. So it was a lot more. But the really fascinating thing, and exactly what you brought up about like what we're missing, is then they asked the players, hey, do you have these? They didn't say the word concussion. They just said, hey, do you have this symptom? Are you forgetful? Are you irritable? Are you having trouble sleeping? 47% had concussion symptoms. They just didn't know that it was a concussion symptom. They just thought it was related to whatever stress, anxiety, whatever else they were going through. So it's really fascinating, to think about how much concussion is out there and how much we're missing, because there sometimes can be some stigma for those kids. They don't want anybody to know that they've had it because everybody knows now about the second impact syndrome and all these things. Say they don't talk about it. But another stigma that's been out there is that people who have been diagnosed with what is considered a mild TBI, right? And these things are hard to grade. They are often stigmatized when they continue to have symptoms because they're just like, it's mild. Why haven't you recovered? What's your thought on that? Like a mild TBI? Can you just kind of educate our audience as to how a mild TBI can be a significant long-term problem?
The first thing that we have to recognize is that as physicians, we're really not good at diagnosing and working with conditions that we can't diagnose with objective measures, with objective evidence. So that if you do an X-ray of the skull and you see a skull fracture, so then we see that. Correct. And we know that there's a high impact there, and we worry a lot about that. If you do a CAT scan and we see a skull fracture, or we see bleeding, whether it's outside the brain or hopefully not, but occasionally we see bleeding inside the brain. So then we have that. We have an objective measure. MRI is an even more sensitive test to look for changes within the brain itself than CAT scan often. The problem is that when you have a mild injury to the brain, most of the time we don't see anything on plain X-ray, on CAT scan, or on MRI. And so then we don't know what to do with that. But we have to understand that that doesn't mean that there's nothing wrong or there's nothing going on. That's just the limit of what we can image. Today, in the last decade, we're looking at other types of imaging, but it's really not widespread in use. It's more experimental or investigational, I should say. We can look at functional imaging. So there are things like functional MRI. You can have somebody who has a totally normal MRI scan after a head injury, but then when we do functional MRI, which actually looks at the way the parts of the brain are talking to each other, we can see that maybe the frontal and the temporal lobes or the deep frontal connections are not normal. So if you go back, 20 years before we were really using functional MRI at all, we would have said that that person was really normal. And, again, person might be complaining of symptoms and they might get marginalized or stigmatized, or maybe you believe them, but we don't know what to do with it.
Right.
You don't know. Worst case scenario, the person's blamed for malingering. They're faking it. There's a secondary gain, for example. Best case scenario, you find a compassionate or empathetic physician who says, I believe there's something going on, but I don't know how to help you. Even taking it to the next level, we have metabolic imaging, which is coming on the scene. And it's hard to know what we're going to find with that, but you start to look at things like the neurotransmitters, right, amino acids, what's going on in the brain itself. Even if the connections look okay, has there been an impact on the way the brain is actually working on a micro level, something we've really never looked at before? So I guess that's a long-winded answer, which reflects the fact that I can tell you that many of these people have something going on, and we're getting better at trying to figure out what that is, which will allow us to help. But as of now, because we're so bad at understanding what's happening, the best thing I think we can do is recognize the fact that we don't really know what's going on. And so we have to try to figure out ways the best we can to help these people. But certainly mild head injury, mild concussion, there's a lot of stuff that's happening, in the person's brain, as evidenced by, as you mentioned, the second hit syndrome. You have a person, the classic example came from boxing years ago, where somebody would take a hit and they get up and they're fine, the second hit, and they die. We've seen that, or something terrible happens. I wish I could give you more definitive answers. I think what we have to recognize is that there's a lot we don't know.
That's an excellent answer, and I think it's easily understandable. Wanted to get into the mechanism of and potentially one of the ways that you can target and improve traumatic brain injury. There's a lot of work out there that is really showing that a lot of these diseases, and or post-injury scenarios are really a mitochondrial dysfunction. One of the things I read was that you get that shearing of the cells in the brain, and that sets off like an immediate cascade, right? And it injures the wall of the mitochondria, and immediately, like the channels, not to get too into depth, they basically open up, and you get this influx of calcium, and now you've got this crazy spiral of events going on, and you get a lot of mitochondrial dysfunction because they can't do anything. They're the powerhouse of the cell. For people that don't know, mitochondria are found in all cells, and they cannot function well. And so mitochondrial targeting may be one of the ways that we can help people, not just with, concussion, but with so many different diseases out there, including, like, for example, like Alzheimer's and some of these neurodegenerative things. There's a lot of work being done on mitochondrial dysfunction. Do you have any thoughts on that?
Yeah, I mean, I think it's heading in the right direction. Again, what I was talking about was the fact that, we can look at this from a macro level and then from a micro level. On the macro level, we're very good. Or, we've got that down. We know if there's a subdural hematoma, a blood clot on the outside of the brain, pushing on the brain, we can diagnose that, we can treat it, we know what we're doing. The problem is really that we haven't been able to devote the time, the research, the money, the funding to fully understand what's going on at the cellular level, at the mitochondrial level is what you're talking about.
Right.
I mentioned neurotransmitters. You start looking at proteins, at enzymes, at how the proteins are being encoded, folding, these types of things.
Mm-hmm.
Mitochondria. This is what we need to be looking at. There was research being done 25, 30 years ago, what we call looking at microdialysis, or the chemical composition within the brain after head injury and other types of injury to the brain. And, the research I hate to say it, the research really died. Ideas like what you're talking about with mitochondria, you're opening up the door to a lot of new and interesting and provocative treatments, which seem to be helping people. Maybe they're working through the mitochondria. That's fantastic. Maybe they're working through another mechanism.
Right.
I don't think we know quite enough, but I think the questions that are being asked are the right questions. Let's try to understand what's going on at the cellular level in a patient who has a mild closed head injury. I get asked these questions sometimes. I'm not a trauma expert, right, in my clinical practice, but you see somebody who had a traumatic injury. When can I go back to playing again? When can I go back to football? When can I go back to this? Honestly, we're making it up. I mean, we don't know. We're not sophisticated enough to differentiate between two people, one of whom had a mild closed head injury, and maybe there's something going on at their cellular level, at their mitochondrial level, and another person who's really actually pretty good, but complaining of some similar problems. So, we have generalized guidelines from looking at a lot of people in terms of what would be safe. But again, it gets back to the fact that we're really not treating them the way, as physicians, we really want to help people.
Right.
We really want to get them better. We want to get them feeling better. And so I think we're not sophisticated enough, but I think what you're talking about is taking us in the right direction.
Yeah. And so I think on the mitochondrial level, that I've become a fairly, I wouldn't say a big advocate, but very interested in some of these treatments using red light and infrared therapies. And one of the things that really, really piqued my interest, and honestly, it's a really well done study that comes out of Harvard, and what they did is that they looked at patients who had what they would consider moderate TBI because they had changes on their brain scans, which was important in that study. But they did a randomized controlled study, and they compared patients who had sham, so basically they had light, like shining a flashlight on their head, versus having a red light, this specialized red light helmet. And the interesting thing is they and others already knew that transcranial red light therapy or transcranial laser therapy can help with the symptoms. That was known well before that. But that study that came out of that institution in 2021, really, it was pivotal, because not only did they show the symptoms were dramatically different at 6 months, and I mean statistically significant across the board, but they also showed significant improvements in the appearance of their white matter tracts on the MRI scans. One of the comments they made is only 3% of that red light actually penetrates the skull, but the red light is then absorbed in the mitochondrial wall and potentially can help to heal. And the question is, if you get red light on there and it changes the way those mitochondria work and they become more functional over time, it's really fascinating. And I think that opens up an entire new way potentially to look at treating patients using kind of transcranial red light therapy or transcranial laser therapy, which is another form of that, just a little bit more powerful. Do you have any thoughts on that? Is that something that you think has some potential down the road?
Yeah, I mean, I'll say a few things. The first time I heard about red light therapy, pretty skeptical, like, if this worked, why haven't we heard more about it, right? But when you look at it, really very interesting, some very interesting, things come out. You look at near infrared and it does penetrate very well.
Correct.
And it penetrates the brain very well. And you look at some of the red light therapy, and even though not a lot of it penetrates, some of it does. Then you start looking at some of the studies from more serious, more reputable institutions.
Correct.
Right. And you see that there is something going on physiologically. There are changes going on. There are changes at the cellular level. There are changes at the mitochondrial level. There's an excitation that happens with the red light or near infrared spectrum of light. It seems that it's doing something. So now we have a physiologic basis for something to be happening. Then you put that together with patients telling you that they're doing better.
Correct.
And then you have to start to ask questions. And I think that's part of the journey, probably, that, that we're talking about, which is kind of unwinding the way we think about things and becoming more humble about all the things that we don't understand. So anytime you have something that's non-invasive, you compare it with there's an idea being thrown around right now for patients with more severe closed-head injury doing deep brain stimulation, putting in electrodes into areas of the brain. Sometimes I've seen talking about 12, 16 or more electrodes being passed through the brain. Well, every time you do that, there's a risk of causing bleeding. There's a lot of danger, infections, really bad things can happen. I'm not saying that we should ignore that. There may be great promise there. On the other hand, you compare that with something that's totally non-invasive. So then we have to start to wonder, are there possibilities here? Is there something there? And I'll tell you one thing, just anecdotally, this doesn't, this is just my own personal experience, which is that I went to medical school. You went to medical school. The last time that I talked about ATP and mitochondria, it wasn't in the last 25 years in my clinical practice. It wasn't during my residency. It wasn't even during research, as a resident or during my fellowship. It was in medical school. So there is a disconnect because the people who taught us in medical school, a lot of them were PhDs.
Right.
Some of them were MD PhDs. They felt it was important for us to understand how mitochondria work, but then we forget it.
Correct.
Then no one talks about it, including, I shouldn't say no one, but, traditionally an orthopedic spine surgeon and a neurosurgeon and a cardiac surgeon and a general practitioner, we're so bogged down with a clinic with 10 or 20
Absolutely.
patients. And then you're in the operating room and you've got multiple surgeries in a given day and you just want to do your best for those patients. I mean, again, I don't want to speak for you, but really until now, how many times as a resident or early in your career did you have a serious conversation with another physician about, hey, what's going on with mitochondria?
I'm going to go with zero.
Yeah.
Knowing what I know and having a lot of experience seeing patients, seeing these diseases. It's very different when you're in school and you're learning about something, but then after years of being in practice, you start going back and you start connecting. Oh boy, like these things are really relevant. But now the more I see it, the more I want to get in those deep science textbook and say, hey, this works this way. I haven't thought about half of this stuff since medical school either. Not half of it. How about 90% of it? Because I'm so busy trying to be the best spine surgeon I can be. But once you get to a certain point and you've seen it, and I don't want to say it's routine. There's nothing routine about what I do or what you do. Once you're more comfortable, man, it's just so much fun to go back and learn about these things. So that's the fun part. The more serious part for me is there's such a health crisis, in this country. And I see it every single day. And I ask them, what are you doing to manage this? How are you being counseled? One more interesting topic that I want to ask you about, something you might not have thought about, but it's really fascinating. I'm doing a lot of research on it now, is this concept of the microbiome and how much it affects the way the brain works. What do you think about changing the microbiome and potentially using that as one of the modalities to help people with concussion or post-traumatic stress?
I mean, this is a huge topic, very important. I think, I believe we're going to look back 25, 50 years from now and sort of be embarrassed by how unsophisticated, we are about it. Whether it's going to be an answer for concussion or any specific problem, I don't know. I mean, I don't know enough about it either, but I'm following the work as it evolves. And, you can't, you have to put your head in the sand to not, look at the overwhelming body of evidence that's being accumulated. It could eclipse, some of the other things that we've been talking about as a unifying understanding of many of the diseases that we treat right now. So super important.
I'm really trying to get a sense and learn from the best and the brightest, but so interesting some of the work that's being done right now on nutrition and how much nutritional changes can literally change the way the brain works, and all the research that's being done, for example, on, major depression and anxiety and all these other things. And there are some really serious, proponents. This is a great book right here, Brain Energy, and I actually by Dr. Palmer, but it's very interesting how they're looking at things like ketogenic diets and going into ketosis and how that can change the brain, and dramatic impacts they're seeing on neurologic disease and psychiatric disease, a lot of which is a huge overlap. And we still don't understand how, if these brain cells are not functioning, how does that make a Dr. Nussbaum come in today and throw a book at me because he's just in a bad, you know what I mean? We don't really know.
Well, I would hope that wouldn't happen.
But it would really be good that would be really, really good for viewership.
But a lot of neurosurgeons, you have to bring in another neurosurgeon, and then you'll have no problem.
Well, I'm going to just say I'll leave it at let a neurosurgeon say that.
Okay.
As an orthopedic surgeon, if I said anything like that, it might be my last interview. For the sake of time and the audience, I'd love to have you back. We should probably pick 10 articles on different subjects and come back and discuss them, outside of our fields, because I think it's fascinating. I think people will tune in and want to know, hey, what are these guys up to? What do they think are things that we should be looking into? Again, we're not necessarily experts in those fields, but how is it relevant to the things that, kind of we're seeing in life? You've gotten really deep down into this, helping people with concussion, helping people with PTSD, helping people that have depression and anxiety. And you've developed something called the Neuro Glove, which you're going to demonstrate on me. I'm excited about it because I haven't tried it before. And I certainly, if it can help me somehow, it'd be great. I'll use it every single day. But tell me about how you got into this, what kind of brought the idea on, and what it does.
Essentially, the idea came from looking at some basic science research that was done 10, 20 plus years ago, looking at stroke. So as a vascular neurosurgeon, I take care of patients with problems with the blood vessels of the brain. Stroke is indirectly related to that. And I try to stay abreast of the literature, including some of the basic science literature. And some amazing work was done looking at mice having a stroke, where it was found that if you stimulated the mouse whisker, the whisker is the most sensitive part on the mouse, so that for man, the most sensitive areas, those that have the greatest representation in the brain, really the hand, in particular the thumb, the face to some extent also. But in the mouse, it's the whisker. And so it was found reliably and reproducibly that you could limit the size of the stroke, limit the effects of the stroke in mice, and even prevent stroke if you started giving them stimulation, that type of feedback,
Fascinating.
early enough, after you stop the blood supply to the brain. And so that suggested, I thought, the idea that one could do something similar in people who were having a stroke, that maybe if you provided sensory stimulation, or what we call peripheral somatosensory stimulation after a stroke, that you could get people better. Intuitively, it makes some sense because of the idea that you're stimulating that part of the brain that is near the motor area, near movement. Also, you're providing feedback. And again, I love the idea of doing something non-invasive, doing something simple, because very hard to believe you're going to hurt anybody doing this. And so we came up with the idea for Neuroglove, which essentially is a device that stimulates the hand and the thumb and the palm, where there's tons of nerve cells bringing information up to the brain. We use puffs of air. So totally safe. We're not even talking about electrical stimulation.
Right.
We're not talking about something that could hurt your hand. We're not talking about something that could cause pressure. And so the first work we did was actually looking at what's called perfusion MRI, looking at the blood flow in the brain. And what we showed was that in some preliminary data, when we applied the Neuroglove, that we increased the blood flow in the brain. And so that was interesting. What we didn't really understand early on was the fact that peripheral sensory stimulation was starting to be found over the last decade by other groups to be beneficial in other conditions. So the first thing we found out about was Parkinson's. There's some great work out at Stanford where providing stimulation, vibrational stimulation, you can go up and look at this data, this literature, it's solid literature, actually was dramatically improving function in patients with Parkinson's. So that is something that's being worked on at Stanford, and we actually are going to be doing a study shortly here in the Twin Cities at one of the major Parkinson's centers using Neuroglove to see if it will be a benefit. Then came across some literature showing that topics that we were talking about, PTSD, anxiety, depression, a lot of other mental health wellness issues may be driven by an abnormality of sensory processing in the brain. And so this is literature going back to the 1970s. Again, I think this is a theme that probably you're finding and I'm finding, is that people have known about this.
Absolutely.
You didn't know what to do about it. And because it wasn't a pill, wasn't a drug, it wasn't being, necessarily endorsed by some big company, big pharma, marketed properly. It kind of fell by the wayside. But all of a sudden we're discovering, hey, this fits with some of the work that's already been done. And so we actually have done a number of clinical trials now, amazingly demonstrating statistical significant improvement in anxiety symptoms, depression symptoms. There are depression scales out there. These are standardized scales. Test people at the beginning, weekly, at the end of the trial, dramatically better. PTSD is another good example. And so, again, I'm not sophisticated enough to tell you at the cellular level what we're doing. We can start to speculate what's happening. But again, it's speculation. But what I can tell you is that we have non-invasive technology that really should be, as best as we can tell, completely benign and harmless. And the patients are improving, including, I think what's been dramatic for me is some very skeptical patients. I love the skeptical patient. The people who've been in our trial, some of them come in and quite honestly, God bless them. I think they wanted to be in the trial to get paid because, we pay the volunteers for their time. They have to use the device every month.
Yeah, just standard stuff. You got to get them in and see what's going on.
Right. And so I have patients who we've had people come in and, when you enter them into the trial, they're like, I've tried everything. I'm on medicine. I'm on this. I've tried cognitive behavioral therapy. I've tried yoga. I've tried this. I've tried that. Nothing works for me. This isn't going to work. I was like, that's fine. As long as you're willing to do it and, and give it a try and give us your honest feedback. That's what we're looking for. And then, they come back at 1 week to do their first, 1 week follow-up after they've been using it for a week. And they go like, I don't know, I feel a little better, but it's probably just because the weather's nice outside. There's been a lot of sun. I'm feeling a little better. I'm having a good week. And then week 2, they're like, I'm a little better. I'm not sure why. I'm like, okay, that's great. All we're asking you to do, here's the 20-point scale. You just fill it out. You just answer these questions and tell us. Week 4, it's the end of the trial. They're like, how do I get one of these? And you feel really good about it. You feel like, okay, there's something going on.
Love it.
Right. And that's happened a number of times now. And that's a great feeling. Even some of these people are like, I'm not willing to admit that this is what's doing it, but I don't want to stop using it either. There's clinical evidence of improvement.
Correct.
Achieving statistical significance. We're certainly not hurting anybody doing it. They feel better. And since we have an underlying understanding of what might be happening, I think the future work is to try to better understand, is it mitochondria? Is it neurotransmitter? Is it both? Is it a combination? But in the meantime, that's kind of what brought me to the point where doing what we do can take you in one of 2 directions. Shut it off and tell the patient, okay, goodbye.
Correct.
Or you can say, let's try something. Let's, maybe this is something that would help you. Maybe not. Again, if you're talking about something super invasive, like putting 16 electrodes
completely different
into someone's brain,
Yep.
I get very, very nervous about that.
And rightfully so, because it only should be used for if it really needs to be used, as like the tools we have, right? As surgeons.
Right. You start looking at some of these options, which are grounded in basic science, and you could hypothetically understand how it might work. And then you have emerging evidence that people are being helped. Let's just say it that way. Why wouldn't you be, if you put yourself in the shoes of that patient, why wouldn't you be enthusiastic about exploring it further?
If the risks are so low, why would our medical community and people themselves not be open, to these things? Some interesting stuff on, like you talk about, we don't know how it works. Patients that had stroke, right? Or like other major things, when they have a good social network, it's incredible how much better they do. It's like dramatic. What if, for example, you have a patient that has a concussion or whatever it is, one of these things we talked about, and you fix their nutrition, which then fixes their microbiome, right? And then you add on things like the Neuro glove, which stimulates certain pathways that are going to help them. You make sure they have a strong social support system, right? You start adding other modalities like red light therapies and other things. What happens if we put all of this together? What happens? I am obsessed with getting answers to this, and we need to start looking at, on a larger scale, thousands and thousands of patients. Now with the help of AI, you can say, you know what, if you do this and this and this and this in these doses, maybe that is kind of for this type of patient, that's going to help them, going forward. And so on that note, since I'm really excited now about the Neuro glove and trying to put it all together, I'm going to see if I can get this up on the table and not be too clunky. I know this part. I'll move my microphone here out of the way, and then I'll give this to you, and you can tell me how should I position this.
Okay.
Best.
So let's do this. And so here's a present for you, which you can keep.
Okay.
So this is a mask that you can wear.
So the mask is to increase the stimulation,
yeah.
Right? Because as you know, you're taking out
right.
We do the same thing that we do with the treatments, because you just get better stimulation.
Right. And so this is actually the clinical prototype that we've been using in our clinical trials. We have the new design, which will include the ability to change out between this chamber, which is the more aggressive chamber, and which is really appropriate for somebody who can put their hand in like this, and you can see the multiple air hoses and the apertures here for the delivery. Some people, what we found is that people after stroke, for example, and some people who have other neurologic issues, can't easily keep their hand in this position. And so initially for some of those folks, you're able to put it on its side, or even just take this out, or even put it like that. But we're going to have the option at this point of either using the chamber or having a quick detach of this and then attaching it to a device that looks more like a glove, where the person actually puts their hand in and it's palm opposed, and it's a very lightweight material so that they can sit with it this way, that way, or to the side. But
so should I put my hand in here?
So you can put your hand in, although it should ideally be palm up, because the majority the majority of the sensation is going to be coming in, and if you put it further in, so that's the concept. And then what happens is that well, you know what we don't have? Plug. So that will help. But we have basically in the back we have an on-off switch. We'll turn off and on. And
is the plug in your car?
The plug is probably at home.
No, but this is, I mean, I understand. And now
And then there's a regulator on the back, which allows you to vary first of all, the duration of treatment and also the intensity of treatment, so that some people will want a lower amount of air pressure.
Okay.
Some people will want more. And so there's a rheostat essentially on the back. Then you can set it for a certain amount of time. And the air puffs are actually generated randomly because, as you could probably assume, the brain learns quickly. So if it was every 3 seconds, it would start to lose the stimulatory input. And so there are different settings in terms of changing it up, some more frequent with greater pauses and some having more intense, but they're all randomly generated. So really a simple concept, interestingly, based on very, basic research. And that's the idea.
Well, that's great. I was really hoping that I was going to get a just this.
You have a three-prong plug.
I was ready to go. I was going to jump in the red green light bed after getting my palm massage here, and man, I was going to write a book this afternoon and just ready to go. But thanks for showing this. I love this idea. I think it's brilliant, and like many things, it just makes so much sense. It's interesting because the way you brought up the conversation about having things that we kind of know work, but it kind of dies on the vine. There's a doc here in town because we are very big with doing exercise under oxygen therapy. It's called EWAT. It's a really interesting concept. It's kind of like hyperbaric chamber, except you're pulling in the oxygen as opposed to pushing it in. But that being said, I sat down with him just to have lunch. We were just going to have a nice lunch and catch up. And I said, oh, this is one of the things that, we're doing, especially, with our athletes or people that are recovering from injury. He's like, yeah, I was doing that for a long time. I didn't even know there was research on it. It's along that same line. There's just a lot of people that have brought these things forth and have treated them on a micro scale, but now trying to get this message out on a much larger scale so that we start doing the research and start doing it on the bigger scales and look at all these methods and see how do they all fit together. It's all one big puzzle. And, if we could be just a small piece of that puzzle, we've won for the people, for the system. So really, honestly, this has been an amazing, conversation. And I think obviously we can go on for a long, long time. How can people learn more about you, and how can they learn more about the NeuroGlove and some of the things you're doing with that?
First of all, you can go to the website, www.neuroglove.net, and we have some patients, people who've tried it, talking about their experience. You can also get a synopsis of some of the research that we've done, multiple peer-reviewed published papers now from some of these clinical trials that we've been doing, and you can see the numbers for yourself. People can make their own judgment.
Right.
And there's also kind of a breakdown about, where things are headed with NeuroGlove. more about me through the practice's website, Midwest Spine, through Brain Aneurysm Center website, which has been my website for a while. You can get information that way. But yeah, I think one of the nice common things between you and me is that we're happy to talk to people. We talk to our patients. We talk to people who, we get contacted all the time. Probably now you're getting contacted about hypercharge and about some of the work that you're doing. I get, through social media, through, LinkedIn, people sending stuff all the time. We have people who want to get the device or want to be in the clinical trials, people who want to just talk about neurosurgery, people who, have a problem with an aneurysm and they're in Europe and they just want some advice. And I enjoy it. I mean, I like talking to people, and this is a good example of that. It's been great.
I agree. I love talking to people. I'll say that being much more active on LinkedIn with this project, and there's docs reaching out. I mean, somebody texted me this morning and said, "Hey, how are things going?" I was like, "I'm just kind of blown away." Are you trying to reach out to the medical community and let them know, sort of directly or indirectly through LinkedIn, that there's a reason, there's research behind this stuff. This is real. If you think the general public is skeptic, right? Our physician colleagues are very skeptical that any of this stuff can work for whatever reason. So how are you going to get around that issue?
What you're saying, I mean, I think, in part, is that there's tremendous skepticism within the traditional medical community, and some of it is unjustified. Some of it may be justified because there have always been snake oil sales.
At 100%. Right?
And so because serious physicians who went to medical school and aren't just trying to make a buck off of a gimmick have not waded into the areas of holistic medicine before, I think it's been appropriate to be skeptical. So one of our jobs is to really look at these options, devices, whether it's red light therapy, whether it's NeuroGlove, whatever it is, and to be honest and fair about it. You don't want to recommend snake oil. You don't want to recommend something that isn't going to help somebody at all. And so a lot of it is about getting evidence. So for us, we put a lot of energy, effort, and financial resources into doing objective clinical trials. This has so far resulted in a variety of peer-reviewed publications. Again, you can look at the data. We have the original surveys filled out by the patients, as I said. We have the individual comments from the patients. Like, here's a good example. We have, one woman in the trial who said that she normally, for her anxiety and depression, which she had both, relies on medicine. And she said when she was having a bad day, instead of taking medicine, she would try the device and it would get her by and she didn't have to take the medicine. I don't feel as though it was my fault that for years I wasn't really thinking along these lines.
We're not trained that way.
Right. We're just not trained that way to think that way.
And there's a lot of people that want us to do other things.
Right. I'm a neurosurgeon. I can be making money operating on patients. And I can just do that all day, every day. But I'm looking at other ways to help people, as we talked about, when they tell me, when at the end of that journey, at the end of the process, you finished instrumenting the spine and your patient's x-ray looks good. And they tell you, but I'm not where I want to be. You can say goodbye and send them off to a physical therapist or a chiropractor who, by the way, I think represent an entire class of professionals who've been, I don't want to say stigmatized,
they have been
underappreciated, marginalized or underappreciated.
I've actually spoken at the Minnesota Chiropractic Association, and again, they're like anything, right? Just like in medicine, there's a range.
But how many people come to you as a physician, and probably more than even to me, I'm as a brain surgeon, but how many people come to you and tell you that they went to the chiropractor and they feel much better?
So many.
Right. So how many times are you going to go like, well, it's all placebo. They don't know what they're doing, because that's how we were trained, right? So you can bury your head in the ground and you can say like, okay, that's pseudoscience. None of it is real. unless we're actually operating on your spine and putting screws into your spine or taking out discs or
Agreed.
things like that, it's not real. Or you can accept the fact that what we do plays a significant role, but there are a lot of very good chiropractors out there, and I don't know what they do exactly, but patients feel better when they leave the chiropractor's office. They're improving. So either you want to include that, incorporate that in some way, or you're just going to ignore it and put your head in the sand.
I started hearing those stories right when I started. I had the opportunity to become really good friends with an osteopathic doctor who did a lot of manipulation. So it was early in my practice that I started talking to people about chiropractic medicine, and people were doing well. So I've been referring people to chiropractors for a long time. I just always ask the one question whenever anybody tells me anything about what they're doing. Is it working? Well, doctor, I've been there for 3 months. I have no improvement. But then that's not what you should be doing. Let's look at these other 15 things that, we could be doing for you. If I say to them, hey, how you doing with that? Oh my God, I feel great every time my chiropractor, they take care of me. I'm like, that's fantastic. Continue with your chiropractor. Maybe we'll add these exercises or hey, I'll talk to them about weight loss or whatever. I think as just the medical community, we just have to open our minds and really get our colleagues on board to just looking at things. And I want to know what they're doing too. I want to know if Dr. Smith down the road is doing some amazing, innovative thing that is like dramatically improving his patients. I want to know about that. Send me the science. If it works, I'd like to offer that to my patients. Is that about right?
I think that's absolutely correct. Because I'm treating really difficult problems and oftentimes where we don't have a good solution for it, one of the things that I've done is at times try something innovative. Try something that nobody had ever done before.
Yes.
Because it's hard, but it's also a privilege to be in a position where the patient's going to die if you don't do anything. So you can either throw your hands up and do nothing, or you can try something. Now we're talking about, to some degree, sometimes more
Right.
invasive or dangerous things, but it's kind of that same concept. Ultimately, it's the same idea. A willingness to try something new or to think about it in a different way, open your mind. Whatever term you want to use.
Well, thanks. This has been amazing. I just want people out there to know that, there's a lot of, physicians and non-physicians, all types of medical providers, so many great people out there, and I'm meeting more and more of them that are really trying to help them. And so for those people that are suffering from concussion and PTSD, and it's really refractory or horrible anxiety, and there's great people out there working on this stuff. And hopefully we can be vessels to get this information out there and just make a difference in people's lives. So thanks again for coming on. It's been great. And I'll see you this week at the hospital.
Okay. Sounds good.
Awesome.
Yep.